Well, welcome everybody, and I'd like to thank you for joining me for this program. Tonight's program is entitled The Oral Cavity Under Acid Attack 2022 Update. And this is a program I've given before. I'm going to give you some of the newer sciences that's emerged in the last couple of years and some things that have changed in the marketplace. So just as a brief introduction, I come from a long family of dentists. My grandmother, pictured here, and grandfather were both dentists who practiced in San Francisco. My father was a dentist, their son-in-law, and I have a brother who's a dentist, as well as a couple of great uncles who practiced dentistry. So dentistry is in our blood. I love what I do on a daily basis and love sharing what I do with those of you willing to listen. So I want to thank you for being here. Just briefly about me, I graduated from University of Pacific School of Dentistry in 1991, immediately returned to teach there and became a full-time tenured professor for 27 years. In 2018, I transitioned away from the dental school and back into full-time practice, where I am fortunate to practice with my younger brother, Jeff, in Marin County, California, just north of San Francisco. And I was blessed and fortunate to practice with my father for well over 20 years. So we have a family practice. We enjoy what we do. We see a lot of geriatric patients with diminishing health. And that really forced me into studying a bit more about the subject we'll talk about tonight. In addition to that, I do a lot of product evaluation with companies that are bringing new products to market, help them position things, give them some insight on the dental industry that they may or may not be aware of, and really enjoy doing that as well. In addition to that, I'm a speaker with a group out of Chicago called Catapult Education. I'm a member of their Speakers Bureau, and I have a very active family, a wife, a daughter, and two sons that keep me busy all of the time. So, as a disclosure, I need you to know that tonight's program is sponsored by Voco, and they are paying me an honorarium to speak to you. With that said, I'm only going to talk about products that I have used and use in my practice, and recommend only those. So I want to thank Voco for their participation in Viva Learning and underwriting the cost for doing this webinar. With that said, we'll get into tonight's subject. Now, tonight we're going to talk a little bit about oral pH, but I want to set the parameters. First of all, right now, all of us sitting here interacting with our computer have a resting pH, a circulatory pH of anywhere between 7.36 and 7.44. Now, keep in mind that that is highly buffered primarily by the liver, and it is at that level at all times. It never varies beyond those numbers. We are actually basic in nature, not acidic. In fact, if our pH drops, circulatory pH drops to an acidic level, we are in some serious health crises, which would land us into the hospital. When you go to the hospital and you've got some issues, one of the first things they do is run a blood panel, and pH will be one of the things they will check. So it's important to recognize that our pH, systemic pH, is balanced and regulated by the liver and the circulatory system. Sometimes our muscle plays a role as well. And we buffer our blood, our circulation, by using certain buffers, and I'll go over what those buffers are. Now, when you think about sources of acid in the body, it is primarily and chiefly from the chemicals of metabolism. As we break down food, we produce acids, and those acidic foods plague our system. Also, as we metabolize energy, sugars, in our muscles, those muscles produce acid. Those acids then need to be buffered. So the sources of bases in our system to combat that metabolism are primarily nutrient driven. With that said, we've evolved to a position where we can create certain buffers, and those are important to recognize. Now, bicarbonate is a common buffer used in circulation to neutralize metabolic acids. In addition to that, we have hemoglobin buffers, we have phosphate buffers, we have some protein buffers, and ammonium buffers. In addition to that, calcium is used as a buffer. So these are all real common circulatory buffers that neutralize those acids from metabolism. Now let's talk a little bit about oral acids of metabolism. And if you think about it, the host of bacteria that are present in our mouths do exactly what we do, and that's break down sugars in their diets and our diets. And as they break down sugars, the byproduct of that is acid. So if we have a high bacterial load, suffice it to say that generally speaking, the pH of our mouth will drop to an acidic position. We're going to get more into that. But as we discuss this further, I want you to think about the diseases that are acid-based, okay? So think about the dental diseases we treat. We treat caries, we treat periodontal disease, which is pictured here. We treat disease of occlusion. We treat erosion, abfraction, attrition. And I would argue that all of those have an acidic component. Now, caries is easy. Perio is easy. And in fact, when you look at the studies that looked at the salivary pH in the incidence of dental caries and periodontal disease in a select patient population, there's a cross-sectional study, what they noted is that those individuals that had a relatively acidic pH were more prone or had a higher dental caries rate and a higher periodontal disease rate. And this was one of the first studies to point this out. And what was interesting about this is if you think about it, the presence of acid in our mouth and active disease makes sense. Those bacteria, those pathogens causing caries or periodontal disease will drop the pH. And this correlation is now well established. So it's important to recognize that those two disease processes have something very much in common, and that is they live in an acidic pH. Now, with that said, caries prefers a pH right around, say, 5.2 to 6.0. That's where the bacteria in caries love to live. One of the points I'll make throughout tonight's program is controlling oral pH. And can you control oral pH, change oral pH, and affect the disease process? And I've often wondered why it is some patients get disease and others don't. And what I've come to conclude is that we've been missing some of the pieces to this puzzle. Now, when you look at this patient with periodontal disease and caries and malocclusion, the three primary diseases we treat, we need to recognize that if we tested the oral pH, we would likely find that this patient's pH is below neutral, below 7.0. Now, systemically, we do not produce acidic saliva. Rather, we produce the saliva exiting our salivary glands when we're not eating, and this is an important distinction, is 7.0. However, if our mouth is acidic from foods we've eaten or from the metabolism of the bacteria we host, our saliva is instantly converted to an acidic liquid by the presence of acids in our mouth. And that's important to recognize. Now, caries is a disease driven by acid. We know that the acids produced in the bacteria produce demineralization on teeth and ultimately will cause the breakdown of tooth structure, loss of tooth structure, and subsequent disease process. Now, this patient here has rampant caries everywhere and is really on his way to what we'd call a terminal dentition, meaning there won't be much left to restore. So one of the things we think about when we're treating diseases is always throwing fluoride at things. But I want to talk tonight about how you strengthen enamel, how you strengthen tooth structure, how you alter the oral flora, how you control and alter pH, and improve oral hygiene to have even a fighting chance for some of these patients. Take a look at the x-rays of that same patient. You recognize that there's rampant caries all over the place, and this poor individual is really faced with what we'd call a terminal dentition. Well, with that said, I want to talk a little bit about glass ionomers. Now, I'm going to divide tonight's conversation into restoratives of two types. The first is restoring caries. Now, when we talk about caries, it's important to recognize that we can have active decay or arrested decay, and we can have a motivated patient or a completely unmotivated patient. I've had plenty of patients who said, well, I keep getting cavities, yet they don't do anything about it. And those patients really haven't demonstrated the ability to alter the oral pH, alter the environment, control bacteria, have adequate hygiene. And for that group of caries-driven patients, what I say is rather than running to composite resins, you should really look at glass ionomers as phase one of a treatment plan. Now, what do I mean by that? Well, these patients who demonstrate an inability to control the disease themselves, if we start putting composites in them, we are doomed to fail. They're going to get recurrent caries. Things are going to break down. So I look at GIs as an underutilized restorative material in the United States. It's quite pronounced use in Australia, New Zealand, and over Asia. Now, I'm going to give props to three companies. First of all, Voco, who's sponsoring tonight's program, for making their Ionostar line of glass ionomers. In addition to that, I really think 3M and GC are two other leaders in what we're talking about tonight. So kudos to those companies. Keep in mind, there are hundreds and hundreds of dental companies, but only really three that I consider highly focused on the area of prevention and caries control. Now, with that said, I want to talk about the non-carious lesions. We have a lot of patients who have lesions that are caused by the effects of acid that are non-carious. For those lesions, I actually consider composite resin the go-to restorative material over GI because of the lack of caries. But with caries, GI has been shown to be quite effective. Now, I talked a little bit about the research since I've last given this program for Voco back in 2020. This is an article that looked at the caries arrest rate with the use of two things in treating caries. The first was SDF, silver diamide fluoride, and the second was glass ionomer. Now, the interesting thing with glass ionomer and fluoride varnish in combination and SDF is they both showed a very high efficacy rate. And if you can get a 90 to 94% reduction in the decay rate of individuals who are disabled or compromised, as this study looked at, that is hugely significant. And this used combination treatment. They used these primarily. Now, what was interesting is they did not see any efficacy close to that with the use of composite resin in individuals with this extremely high caries rate. This was published in October of last year, and it was really important, a very profound article that really looked at the efficacy of glass ionomers. So I want to really reiterate, if you're treating someone with a high caries rate, look at glass ionomers as a go-to. Now, the glass ionomer I use quite a bit is Voco's Ionostar Plus. Now, the main difference between Ionostar Molar and Ionostar Plus is Ionostar Plus is a fast set material. where the Ionostar Molar is a slow set material. They both have relatively similar radiopacity, although Ionostar Molar is slightly higher. Both have a very high fluoride release, and I really like the handling and placement. The problem is we have to be able to control moisture to some degree with glass ionomers. We don't want things getting dripping wet as the material's setting. So I like to work quickly. And that's why I choose to use the Ionostar Plus over, say, the Ionostar Molar, which is a slower set. But these are beautiful products for those individuals who cannot get the disease under control. This has really become my patch and pray material on geriatric patients where you've got recurrent decay on the distal 31 and the tooth is, near bombed out, and you're just trying to get them along and not do anything all that invasive. I used to try and patch things with amalgam. That's how old I am. But that just didn't work. It was cumbersome. Teeth would end up going pulpal. But using a glass ionomer is a really, really handy tool in these individuals. Now, take a look here. This is a patient that I treated with Ionostar Plus that had a very high caries rate. These lower anterior teeth were failing. Interestingly, I tried composite resin first, and we try things, we learn from those things, and then we move on. But the reality is this did not work. The composites got recurrent caries within a year because there was no real active fluoride release that we see in a glass ionomer. And I said, I've got to transition away from that and move to the use of glass ionomers on these patients. And lo and behold, the caries rate decreases. Now, the nice thing about a glass ionomer on one tooth is it's releasing fluoride into the environment on the tooth to the teeth next door. And that's why you saw in that study I just showed you such a high decrease in the caries rate. So I think that's really, really important to recognize. Now, I want to talk a little bit about acids from the stomach. Okay, so what are sources of acids in our mouth? First of all, we can ingest acids. We do that through what we drink and what we eat. Now, that's primarily how acids enter our mouth, or they're in our mouth from the metabolism of the bacteria causing both periodontal disease and caries. That's really the source of acids in your mouth. But there is a third source that we need to consider, and that is the acids that may enter from the stomach. Now, this is a picture of human anatomy, and I want to draw your attention to this area here. This is the lower esophageal sphincter. That esophageal sphincter controls the stomach contents from exiting into the esophagus. You have an upper esophageal sphincter right about here that helps, but this is the primary sphincter that controls stomach acids from leaving. Now, what is GERD? GERD is a chronic disease, and it is described as acids entering the mouth at least twice each week, or you'll get a diagnosis of GERD if a physician sees damage to the esophagus. And it's really important to recognize that those are the two distinctions. And really what's at play here is that lower esophageal sphincter. I'm going to talk a little bit about that and give you some clues. But keep in mind that 1 in 5 US adults have GERD-related symptoms. 4 in 5 GERD patients experience nighttime symptoms, and 75% report that those symptoms affect their sleep. Now, it's important to recognize that this is a very common condition in geriatric individuals. In fact, you'll see a lot of signs of GERD or acid reflux in the oral cavity. How do you get to the bottom of it? Well, you get to the bottom of it by interviewing your patient, asking them, do they have a sour taste in their mouth? Do they have a burning sensation in their throat? And it's important to recognize that a lot of your patients do. When you look at the teeth, you see erosion caused by acids. And if so, is it more profound on one side than the other? If so, that may be the side they sleep on, and they may be pooling acids at night unbeknownst to them. So I see signs of GERD all of the time. And I, initially would say, well, is this erosion from acids in what they're eating or drinking, or is it erosion from another source of acids? Now, interestingly, it's important to recognize that there are some medications and supplements we take that can actually irritate the lining of the esophagus and mimic what a physician is looking for in esophageal lesions to give a diagnosis of GERD. And it's important to recognize that the iron pills are common, bisphosphonates, potassium supplements, and antibiotics, and some of the NSAIDs can mimic esophageal lesions and confuse a physician in their diagnosis of GERD. In addition to that, there are a lot of drugs that decrease lower esophageal tone. What that means is if individuals are on these drugs, the ability to contain stomach acids to the stomach is decreased by these medications, meaning that esophageal sphincter will relax, open, and as such, when the patient lays back, they can get acids entering their mouth. There are quite a few of these drugs that can cause this. The anticholinergics and the benzodiazepines are commonly prescribed. Nitroglycerins are another one. A lot of antidepressants you need to recognize can cause this. Nitrous oxide, propofol, and the big one that on here, even though I listed as number 15, they're not in really importance, is calcium channel blockers. A lot of your elderly patients will be on these to help control blood pressure. It's important to recognize they have a side effect of lowering that esophageal tone. Now, there are some drugs that increase lower esophageal tone. They're fewer and far between, but it's important to recognize that these do exist. Sometimes they're prescribed for patients with anti-reflux or acid reflux. And it's important to recognize that number 14 on this list, antacids, actually help not only neutralize stomach acids, but can have an effect of tightening that lower esophageal sphincter. So I often talk to patients who have sign of acid reflux or symptoms of acid reflux to have themselves checked by their physician and consider the use of sugar-free over-the-counter antacids to try and see if they can really decrease that acidic feeling they have on a routine basis. Now, it's important to recognize that caffeine, unfortunately, and alcohol have a profound effect on the lower esophageal sphincter. They do, in fact, decrease lower esophageal tone. That's why people who drink late at night will often go to bed and can report that they had burping or acids all night long. And that's because that sphincter is not controlling or doing what it needs to. Coffee has the same effect. And a lot of people say, well, if I drink coffee late at night, I don't sleep well. Now, it may be the caffeine, but it also may be acids coming to their mouth, making them extremely uncomfortable. So that's important to recognize. Okay, so we've got our glands, our product glands, and they produce our saliva for us. And as I mentioned earlier in the program, that saliva is coming out at a pH of 7.0 from those glands. That's what our system produces. And it's not until they immediately hit the oral environment that the oral environment is acidic will the pH of that saliva change. Okay, quick question. Which of these drinks is most erosive, meaning most likely to dissolve your tooth structure? Okay, look at them real quickly. Pick one. I'm going to give you the answer, but the answer is, in fact, Red Bull. And we published this article several years back. Myself, Ward Noble, and Terry Donovan in the Journal of the California Dental Association, where we actually measured what's called the buffering time required to neutralize these drinks. And what we found is that one swig of Red Bull takes approximately 22 minutes to neutralize. One swig of Gatorade took 21 minutes. One swig of Powerade took 18 minutes. And oddly enough, Coca-Cola was buffered very quickly, in about 2.5 minutes. So while some of you may have guessed Coca-Cola is the most erosive, it is not. Now, if I'd ask the question, which of these is the most acidic? Coca-Cola would be correct. Red Bull would be absolutely the wrongest answer, the most wrong answer. So when you think about this, pH and erosiveness are not necessarily tied together. What's more important is what acids are present. Now, the difference between Coca-Cola and the other three are that Coca-Cola contains phosphoric acid at a pH of 2.6. The others contain citric acid at a very low pH as well. But citric acid is incredibly hard to neutralize. It requires a lot of saliva to be buffered. Whereas phosphoric acid, the same stuff we rinse with, rinse off when we etch, really neutralizes very quickly. So it's important to recognize that the type of acid in drinks is really important. Now, I get questions on what's in what we drink all the time. Let me just say this: human beings like the taste of acid. So most of the things we drink contain phosphoric acid, carbonic acid, citric acid, malic acid are really the most common. Now, coffee's pH is about 4.3 to 4.6. It's a little higher than most sodas or soft drinks. Unfortunately, carbonic acid is present in carbonated water, so its pH is actually quite low at 3.4 to about 4.0. Tea, depending on the color of the tea, black tea is quite acidic. Green tea is one of the few drinks that has a pH basic and actually is not acidic. With that said, green tea is a tremendous stainer of dental teeth, and it's worse than black tea, believe it or not. I also get questions on alcohol, and it's important to recognize that most of the things we drink in the alcoholic version are very acidic. And in fact, my kids are of a generation that they really go towards those hard seltzers. But let me tell you that a hard seltzer and vodka contains citric acid. And as you learned earlier, citric acid is one of the hardest acids to neutralize. So those hard seltzers, the White Claws, the Trulies, those are really, really hard to neutralize because of citric acid and their incredibly low pH. So those would buffer in a long period of time, well over 20 minutes. Red wine and white wines have similar pHs, although generally speaking, white wines are a little more acidic than red wines. And the lighter the white wine, the more acidic. So something like a Sauvignon Blanc will be more acidic than a Chardonnay. A lighter red wine, something like a Pinot, would be more acidic than a darker red wine like a Syrah or a Cabernet. Beers are all over the map, but wheat beers tend to be slightly more acidic than barley-based beers. Now, why do I bring up what we drink? Well, it's important to recognize that an article published in JADA in April of 2016 clearly showed that 93% of the beverages sold in common grocery stores had a highly acidic pH of 4.0 or lower, and that only 7% of the observed drinks in our grocery stores had a pH of over 4, which is actually quite frankly frightening for patients. Now, I think that this article is incredibly important. It was published in 2016. I have this article as a reference for you. I also as a reference for patients because it lists all these drinks, and it's shocking. But more importantly is not what their pH is, but what is the primary acid present. So I counsel patients on reading the labels of the things they're drinking. If they see citric acid, put it down and walk away. Now, I want to talk about some strategies for you because our patients are really the ones with all of these issues. And I have 5 strategies that I want you to consider tonight. And I'm going to go through these pretty darn quickly. Okay, the first 2 are to measure and alter pH and dietary counseling. And I feel that those are our responsibilities. The second 2 are a shared responsibility between the patient and the doctor. One is to control and alter bacteria. We do that by cleaning their teeth. They do that by hygiene at home. Strengthening tooth structure. We do that by applying fluoride varnish, by applying different versions of fluoride, by giving them calcium and phosphate in some either dentifrice or gel. They do it by brushing at home. And then finally, enhancing salivary function, which is really the patient's responsibility. We can't increase their salivary function without their behaviors change. So let's talk about the first two, measuring and altering pH. Now, when you measure and alter pH, it's important to recognize that what you're testing when you measure oral pH is the pH of the oral environment. It is not the pH of the patient's saliva. Even though they're spitting in a cup with saliva, that saliva came out of their salivary glands at a pH of 7.0, but hit an acidic environment and the pH immediately dropped. So I talk about increasing water consumption, changing toothpastes, and potentially sodium bicarbonate rinses. Okay, when you talk about water consumption with patients, it's important to recognize that the Institute of Medicine has very clear guidelines on this, 3.7 liters a day for males, and this is total dietary water. And that what it means is water that may be in fruit you eat. They say you eat an apple or a cantaloupe. And for females, it's 2.7 liters a day. With that said, roughly 2/3 of the water we get will come in a liquid form of some sort. Water, milk, coffee, you name it, it's liquid form. The other third will be removed from the foods we eat. And it's important to recognize that physical activity will drive up the need for water. So what do I use? This is a product from GC called the Salivary Check Buffer. I use this on my new patient population, and we test their pH. We do this in really 3 phases. First of all, we test what's called their resting pH, meaning they spit once in a cup. I take their saliva and measure the pH of their mouth. And generally speaking, if their mouth is balanced, they don't have a lot of active disease, the pH will be 7.0. However, if they've got active disease or an acidic mouth, and those acids could be from something they ate or from the bacteria reproducing in their mouth, their resting pH will be acidic. That's a problem. That favors disease. Then we check what's called stimulated pH by having them chew on wax and spit for 5 minutes. When we do a 5-minute chew test, we should see an increase in the pH. So their stimulated pH should go up to around 7.8. As soon as you start to chew, you send a message to the brain that says, we're eating, we need to neutralize acids, and your salivary glands release calcium, phosphate, and other buffers, just like your liver does in your circulatory system. We are perfectly designed to do that. Now, there is a lot of evidence that says grinding your teeth is a way of tricking the brain into releasing buffers. So there is a high correlation in people with, guess what? Acid reflux disease and nocturnal bruxism. They are bruxing to protect their oral environment. So it's important to recognize that. And we then measure and test their buffering ability with the 3rd phase of this, and we see how well their own saliva neutralizes 3 strengths of acid. Now, there are other ways you can test pH. You can get these from Henry Schein or whoever you deal with. These pH strips, Green First, Hydrion, or pH Health. And send patients home to test their pH. Patients actually are, I find them quite interested in this. Now, there are 2 codes that you can use to do this. D4018 is for the analysis of a salivary sample, and D0419 is the assessment of salivary flow by measurement. When you perform that test I just showed you, you are actually doing both of these, and these are billable to insurance companies. So those are the codes you would use. All right, I want to talk a little bit about toothpaste. When I ask patients what toothpaste they use, it's almost always a whitening toothpaste. They can never remember the name, but they can tell me it's a whitening toothpaste. One thing I want you to recognize is that whitening toothpastes are highly abrasive. Their RDA value, or relative dentin abrasion value, is very high. Doesn't matter who makes it. Where do I live with toothpaste? I live in the low abrasive toothpaste, because in the presence of acids, if we're cleaning off acids from our teeth and we're combining those acids with an erosive or abrasive dental toothpaste, we can actually cause further tooth loss by just brushing alone. So I get patients to use a pH balanced toothpaste, one that contains sodium bicarbonate. So Sensodyne's a good brand, and Arm & Hammer is another great brand, that are low abrasive toothpaste. Now, in dental school, I was taught that baking soda is highly abrasive. We were lied to. Its RDA value is 7. Complete Care from Arm & Hammer and Pronamel from Sensodyne are both considered low abrasive toothpaste. But here's one that I hear patients use all the time: Advanced Whitening from Colgate, 200 RDA value. What that means is it's highly abrasive. So I steer patients away from these abrasive toothpaste. Now, when we talk about an alkaline mouth, how do you increase an alkaline mouth? There are several things. First of all, fluoride can do it. Varnishes can do it. Increasing bicarbonate, calcium, and phosphate can do it. Increasing salivary can do it. Good bacteria can do it. Calcium-rich foods, xylitol, and probiotics are all strategies that we'll go over. Keep in mind, I want you to think about calcium, phosphate, fluoride, and xylitol. Those are big for me, and we'll talk about those. An acidic mouth comes from the things we eat, the things we drink, sugars that provide the bacteria a way of reproducing and metabolizing that and producing acids. Low salivary flow favors an acidic environment. And of course, any stomach acids due to things. Now, I also talk to patients a bit about dietary counseling, and I could do a whole day on this alone, but suffice it to say that an article in JADA in 2010 really changed how I think about my role as a practitioner. This is an important article about the dentist role in curbing obesity and health issues with patients. But you got to start somewhere. And I talk to patients primarily about what we eat and drink, not from a health standpoint necessarily, but from a dental health standpoint. First of all, it's important to recognize that your resting pH should be 7.0. If it's below that, you've got to change the oral environment. And that when you chew, that pH goes up to 7.8. But here's the problem. When you drink, nothing changes. Meaning, if I take a swig of Red Bull, Coca-Cola, whatever, Mountain Dew, you name it, my pH does not change. When I chew, it goes up to buffer food. Well, why wouldn't the pH change when we drink something? Well, that's because nature provided us with two things to drink: milk in youth and water as an adult. Well, milk is a highly buffered product. It's generally speaking 6.5 to 6.7. Pasteurized milk is a little lower. Say breast milk would be at 6.7. It is essentially pH neutral, even though it does contain some acids. The calcium and phosphate present in milk buffer it. It's perfectly buffered. Water is normally a pH of 7.0, but that is not always true. Now, this is important to recognize that that tap water is highly regulated, pH is balanced, but bottled water is not. Now, one thing I'll tell you about bottled water is, generally speaking, bottled water, and this is a great test question, so listen up. Bottled water contains more minerals than tap water. Not only that does bottled water contain more minerals, it has a variety of pHs. So look at all of these drinks. Now, I put two types of smart water here: the original smart water, the blue one there, and then the newest one, which is smart water alkaline. Now, it's important to recognize that Essentia was the first alkaline-based water out there with the highest pH of 9.5. Smart water is just launched this last year to the market. It's an alkaline-based water. Evian is 7.3. Smart water is 6.7, the original. And then we get to Fiji, which is slightly acidic. And then we get to these from other companies that are extremely acidic. 5.6 from Dasani and 5.9 Aquafina. Those are troubling waters. Why? they actually tip the oral environment to favor disease processes and to favor tooth loss. Imagine that you're drinking water and eroding your teeth simultaneously. Kind of scary. Propel Fitness Water is nothing more than marketing of Gatorade. It is from Gatorade. It's clear Gatorade at a pH of 3.3. And guess what? It's loaded with citric acid. So goodbye teeth. So stay away from those type of things. Now, I want to caution you about this whole trend towards alkalining waters. While they may be good for the oral environment, if you're drinking a lot of alkaline water, and that goes directly to your stomach, that alkalinity will neutralize stomach acid. And physicians have seen an increase of digestive issues in individuals who are drinking alkaline-based waters. Why? If they've just had a meal and their stomach is releasing hydrochloric acid to break down that food, and you chase that down with a bunch of alkalining water, you'll neutralize those stomach acids and you can delay the digestive process. So we got to be real careful with what we're drinking in water. Where do I live? I live in the middle of this screen with waters in a pH kind of neutral zone. One thing I tell patients is shop their perimeters. Those foods are less carcinogenic, less disease promoting, and far healthier for you. I also like to tell them to stay away from the center of the market. That's where all the dangerous things live. And it's important to recognize that you can give them some apps, say Choose My Plate or Tap and Track or Fujicate, or any of these apps work really well for patients. Now, I want to talk about the shared role of the dentist and the patient. We're going to provide patients with some modes of controlling acids in the diseases they have. For years, we threw fluoride at caries, and I honestly have to say, I didn't see a lot of effect. Patients will still come in with root caries. So how do we strengthen tooth structure and control and alter bacteria? Okay, I want to talk about what I mentioned in creating an alkaline environment. And that occurs from fluoride, from xylitol, from calcium, and phosphate. So when you look at these three products here, these are three products from Voco, 3M, and GC. I love Vocos for the flavors and for the presence of calcium, phosphate, and fluoride in a xylitol sweetened delivery system. With Remin Pro from Voco, this is a great thing to brush on your teeth before bed. That presence of calcium and phosphate will not only help to strengthen tooth structure, which is highly important, but it also helps to raise the oral pH and counter the effects of the bacteria. Not only that, when you raise the oral pH, the bacteria simply don't like it. They don't thrive in a basic pH. So what we've been missing all these years in treating dental disease is really this concept of not only controlling bacteria, but controlling the environment they live in. So Remin Pro, it supports remineralization, strengthens teeth, neutralizes acids, and has a great taste. It's got xylitol, which is anti-cariogenic or cariostatic, and it's important to recognize. Now, in addition to that, you need to look at increasing fluoride varnish, and I'm going to show you the evidence on this. Fluoride varnishes are highly effective, and they've been shown to be present up to and active for 2 months. So if you have a patient on 6-month recall, recognize that about month 2, that fluoride varnish is no longer effective. However, if you're seeing them for routine dental care, dentist, I need you to get in the habit of applying a fluoride varnish to keep that fluoride concentration high. Now, these are 3 common products. Pro-Fluorid varnish from Voco is one that contains 5% sodium fluoride. In addition to that, it has calcium, and which is a great desensitizer, this varnish, as well as a neutralizing effect and anti-cariogenic effect. So this works beautifully, a great product. Up your fluoride varnish game. And then finally, think of producing and doing more sealants. Now, why do we seal? We seal to prevent caries and bacteria from living in those grooves. If your grooves of your teeth are full of bacteria, those bacteria are reproducing and increasing the acid level in the mouth, promoting disease processes. So up your sealant game. And these are 3 common sealants I use all the time. Grandiose Seal from Voco is a great sealant material, and I highly recommend you use that. Now, what does the caries prevention evidence say? This is new. This is a new article that was published in late 2019, a meta-analysis that suggested 5% sodium fluoride varnish, we just talked about that, Plofurid varnish, with resonant infiltration, 5% sodium varnish alone, and 5,000 part per million fluoride toothpaste were the most effective at arresting or reversing non-cavitated occlusal, proximal, and non-cavitated and cavitated root caries. And this is huge. This is extremely important. So when we talk about evidence-based dentistry, we need to keep this in mind. The next thing I want to talk about is gum chewing. Xylitol is very effective, but only at an effective dose, which is between 6 and 10 grams a day. Now, it's important to recognize that the one gum I recommend for patients is a gum called Hershey's Icebreakers or Ice Cubes. The ice cubes contain 1.15 grams of xylitol. What that means is based on the patient's different size, and I divide patients into small individuals, medium-sized individuals, and large individuals. They would need between 6, 7, or 9 pieces a day to get to a therapeutic dose. But keep in mind, if they're using Remin Pro, they're getting a gram each time they apply that material. So you have to count the total dietary intake of xylitol between 6 and 10 grams. Now, things like Mentos or Trident will say we've got xylitol, but take Trident, for instance. It's got 0.14 grams of xylitol. What that means for a small individual to get to 6 grams, they would need to chew 43 pieces. A large individual to get to 10 grams would have to chew 71 pieces of gum a day. That is simply not realistic. We need to recognize that. Spry is another good one. It contains 0.2 grams of xylitol, and that's highly effective. Theramints from 3M have 0.5 grams. They're about the size of a baby aspirin. So for people who don't like chewing gum, this works. I'm a big proponent of gum chewing. Why? It increases the oral pH. Gum chewers, interestingly enough, have a very low disease rate. And I would argue the reason they do is they're constantly buffering their saliva. And that saliva is neutralizing acids and preventing bacteria from taking a stronghold in the oral cavity. And then finally, I want to talk about enhancing salivary function. This is really, really important. Patients need to know how to do that. When you measure the volume of saliva they produce in a 5-minute test, it should be anywhere between 15 and 30 mLs. If they're at 10 or under, they're borderline xerostomia. 5 and under is considered xerostomia in a 5-minute test, which you'll do with the salivary check buffer system. And proper hydration will actually increase salivary function and increase the pH of their saliva. So I've had patients on water programs to get salivary uptake higher, and also gum chewing is a program to increase the salivary output. And we need to recognize that those are very effective. Now, with that said, this gum chewing also helps increase salivary output. It's very odd. If you put a patient on a month of gum chewing, say 1 piece in the morning after meals, 1 piece in the afternoon after meals, and then 1 piece before bed, or 2 pieces, whatever, you'll notice that if you remeasure their saliva, they have higher salivary output. Why? They're stimulating salivary production by chewing. That's important to recognize. So it's a very effective way. Again, I usually refer patients to Icebreakers, which are xylitol-containing sugar-free gum. Now, with that said, I want to talk a little bit about class 5 lesions. We've got carious lesions, abfractions, erosions, and abrasions. And I think really when we talk about diseases, These are untapped areas in your practice. Now, I talked a lot about caries and using glass ionomers, but when it comes to abrasion, abfraction, or erosion, I really turn to composite resins. Now, upping your class 5 game is extremely important. Now, there's really two approaches I want to talk about. The first thing I do with any class 5 is I avoid what we would call the standard bevel and move to what we call the irregular bevel. The irregular bevel will help hide your restoration quite beautifully. When you do these, you want to select a flowable composite, and I'll show you one example of that. And you want to select that flowable based on its handling properties. Not only that, you need to consider what class 5 lesion do you have? Are you solely on root structure, or is your class 5 lesion on both enamel and dentin? And that should then determine what you use. Now, Voco makes Admira Fusion Flow, comes in 12 shades, very, very low shrinkage based on their nano Ormasur technology. And that helps flowables shrink less. In addition to that, it's silicon oxide base with no glass, and it's filled with that silicon oxide at about 74%. This is quite thixotrophic. It's nice for class 5s because it doesn't run all over the place. And I really do like using flowables to restore all non-carious class 5s. And then you need to think about your adhesive protocol. When you think about an adhesive, I really strongly suggest on class 5s, you look for a self-etching adhesive that allows you to total etch, selective etch, or self-etch. And that can be done using a 6th or 7th generation adhesive. Now, this is Futurabond U from Voco, which is a great 7th generation adhesive. And it allows you the flexibility of, say, using a total etch if you're on enamel, a self-etch if you're on dentin exclusively, or a selective etch when you're on a combination lesion. Now, I want to give you a few examples of restoring these class 5s. So here are 2 abfractive lesions, probably have some erosion as well. They're non-carious class 5s. Yet they're quite pronounced. And I always talk to patients about, hey, this is your pulp we see right here, your former pulp, right there. It's receded away. I've had patients who abfract or erode into their pulps, and the teeth turn endo. So what I do with these first is I'll come in and place a cord subgingival on each of them. I've got an isolite in place. It's really hard to put a rubber dam on for these, so I'll use an isolite. You can see how dry and leathery the tissue is. I'll come in and I'll do my irregular bevel. Now, this is not a standard bevel, it's an irregular bevel. From there, I'll sandblast, and then I'll apply a self-etcher. After I cure that, I'll apply a flowable, and we'll place that flowable and use an explorer tip to move that around. And we'll do this in increments. And we want to find a flowable that we like. At that point, we get 2 increments in, we light cure. We fill the rest of it and light cure. Then we'll take a fine carbide and finish these back. And that irregular bevel will help hide these perfectly. So after we polish them and we look at them, they're flawless. They'll protect those roots for ages. Now this, we'd either use a self-etch, like I demonstrated here, or a selective etch. A selective etch would take a product, a 6th or 7th generation adhesive like Futurabond, and in that case, you would etch the enamel only. So we got our cord in place. This is what's called selective etching, and this is highly effective for these combination lesions, where we then apply our self-etching liquid, scrub that in, air thin, light cure, and then restore with our flowable, get that all restored, contoured back, polish it, and these will literally disappear for you. So those are some things I want you to think about in treating some of these acid-driven lesions, the non-carious class 5s. Now, why do I say abfractions are acid-driven? Well, oftentimes they are because the patient is bruxing at night for a reason. They may have sleep apnea, but they may also have some acid reflux that is triggering them to grind. So keep in mind that acids play a huge role in everything we've talked about in this program. Well, with this said, I'm going to leave my last slide up here, and I'm going to go to a few questions. I've got just a few minutes for questions. I apologize in advance. I will not be able to get to everybody's questions. With that said, I'm putting my email here. If you want to email me, feel free to do that. So I'm going to go ahead and open my question bar here and see see if I can answer some of these questions. So I'll read the questions first. Okay, so this is a great question from, I hope I pronounced this right, Denna. Denna asks, is calculus also related to pH of the mouth? I usually see either a lot of decay or heavy calculus. I have a few patients with both. Is there a reason for that? And I've pondered this question as well, and unfortunately for you, I do not have an answer. However, we know that tartar or calculus is the deposition of calcium. So we have to recognize that. And I'm not 100% certain that there is a pH relationship. I haven't found one. So the next question I have is, are some people, this Ryan asks, do some people have naturally acidic or alkaline saliva? And Ryan, generally speaking, the answer is no, because the saliva we produce when it exits the salivary gland is generally right at 7.0. However, it becomes acidic or alkaline when it comes into an environment that is either or. So it's really the oral environment changing what we would say is the salivary pH. And I don't know, Ryan, if Smart Water Alkaline promotes calculus buildup. That'd be an interesting correlational study to run. Take those people who are committed to alkaline waters and see. I've got another question. If you're not actually getting 6 grams of xylitol a day, will 3 to 4 grams help? Gosh, Angela, I don't know that it would necessarily help, but I think it's a valid question. I don't think it would hurt, especially if they're getting the xylitol through gum chewing, because that gum chewing would increase salivary production and would increase the buffering in their oral environment. So, in some ways, while it may not be the anti-karyogenic effect that you get from that 6 to 10 grams, I actually think it would be beneficial because you're ingesting that xylitol by chewing gum and raising your pH. So thank you for that. Brenda's question. Oh, Brenda just said thanks. You're welcome, Brenda. Thanks for being here. So Ryan asked another question. Did you fill the class 5s with only flowable? Yes, Ryan, for the last 12 years now, I've only done flowable composites in class 5s. And it does not stain over time, interestingly enough. Flowables now are highly filled. They may be less strong, and not really less strong, they're less wear resistant, but we're not putting them in occlusal load in a class 5. Not only that, because they're a little less filled, they actually flex a bit more. So that's important to recognize. Well, with that said, I had a couple more thank yous. So I want to thank everybody for tonight, and feel free to email me with further questions. And I'm going to turn it back over to Trong to end our program. Thank you all for being here, and have a great evening.